Hello, everyone. In this talk, we will connect invasive hemodynamics to bedside decision making in shock. The central message is simple: right heart catheterization is not just a numbers exercise, it is a physiological tool that helps us identify the shock type, estimate severity, and choose the right therapy before organ failure becomes irreversible. Slide two. The clinical escalation arc. Think of this like a four-step escalation arc. First, secure access, then obtain trustworthy measurements, then apply those measurements to pulmonary hypertension and shock, and finally synthesize the data into treatment decisions. That structure matters because in critical care, bad measurements lead to bad decisions, and delayed decisions cost myocardium, kidneys, and brain. Ultrasound guided access. The modern standard for vascular access is real-time ultrasound guidance. It improves first-pass success and reduces complications compared with landmark techniques. For a right heart catheter, the right internal jugular vein is usually preferred because it gives the most direct path to the right atrium and the pulmonary artery. Before placing a central line, we can use a Rakeva or rapid central vein scan both sides in a fixed sequence, starting at the mid-interjugular, moving to the base of the neck, then the brachiocephalic and supraclavicular region, finally the infraclavicular axillary vein and pleura. At each step, you check patency, size, compressibility, arterial relationship, and pleural safety. The goal is simple: choose the best vein first, then cannulate it under real-time ultrasound guidance. Core metrics from right heart catheterization. The catheter gives us the core language of hemodynamics: right atrial pressure, pulmonary artery pressure, wedge pressure, cardiac output, cardiac index, mixed venous oxygen saturation. Together, these numbers tell us whether the problem is preload, pump failure, afterload, or impaired oxygen delivery. Without that framework, shock can easily be mislabeled. Thermodilution versus indirect FIC. For cardiac output, the two common methods are thermodilution and indirect FIC. Thermodilution is usually the bedside workhorse. Indirect FIC can be useful but becomes less reliable when oxygen consumption is assumed rather than measured. It is important that the method matters because classification and treatment can change if the output is wrong. Redefining pulmonary hypertension. Right heart catheterization is essential for diagnosing pulmonary hypertension. The newer definition lowers the threshold to a mean pulmonary artery pressure above 20 millimeters of mercury, and precapillary pulmonary hypertension also requires an elevated pulmonary vascular resistance. The point is earlier and more precise phenotyping, not just a label. Advanced right ventricular assessment with PAPI. One high-yield metrics for right ventricle is a pulmonary artery pulsatility index, or PAPI. The formula is systolic pulmonary artery pressure minus diastolic pressure divided by right atrial pressure. A low PAPI suggests the right ventricle is failing to generate pulsatile flow and should immediately raise concerns for RV failure. The Society of Cardiovascular Angiography and Intervention shock update. The SKY shock classification gave us common language for shock severity. That matters because teams communicate better when they use the same staging system, and it also correlates with prognosis. Instead of saying a patient is sick or unstable, we can describe exactly where they are on the trajectory from risk to extremity. The three axis model. The updated framework is more than just stages A through E. It also asks us to define the phenotype, such as left ventricular failure, right ventricular failure, or mixed shock, and to consider risk modifiers like age, lactate, cardiac arrest, and comorbidity burden. In other words, shock severity is not one dimensional. The clinical pyramid. At the base of the pyramid are patients at risk. As you move up, hypoperfusion becomes more evident, support requirements escalate, and mortality rises. The value of the pyramid is that it reminds us to act before the patient reaches the narrow top. In shock, waiting for collapse is not prudent restraint, it is missed timing. Shock has a dynamic trajectory. Shock is dynamic, not static. A patient can worsen from one stage to the next over hours, but they can also improve if therapy is timely and targeted. That is why repeated clinical and hemodynamic reassessment matters. A single catheter number is a snapshot. The trend over time tells the real story. The critical modifier, cardiac arrest. The A modifier highlights cardiac arrest because it changes both prognosis and neurological context. A patient who has had arrest is not simply a higher number shock stage. That patient has a fundamentally different risk profile, and decisions about escalation must include neurological recovery, end organ injury, and the goals of care. Lactate. Crucial but nuanced. Lactate is helpful, but it is not a synonym for shock. A rising lactate may reflect tissue hypoperfusion. It can also be influenced by beta agonists, impaired hepatic clearance, or chronic illness. Use lactate as one piece of the puzzle. The best habit is to interpret it with perfusion exam and findings and hemodynamic data. The hub and spoke model for shock systems. Not every hospital can offer advanced mechanical circulatory support. That is why hub and spoke systems matter. Community sites stabilize, identify the phenotype, and transfer early when needed. Shock centers provide advanced devices, multidisciplinary expertise, and continuous reassessment. The important point to remember is that early transfer is often a life-saving intervention. When you put the first half of the talk together, the sequence is access, measurement, interpretation, and triage. That is the vital pulse of hemodynamic care. The catheter itself does not save the patient. What saves the patient is timely interpretation of the data and acting on it before spiral pathophysiology takes over. Differentiating shock with invasive hemodynamics. One reason we place a catheter is to separate shock phenotypes that may look similar clinically. Cardiogenic, septic, hypovolemic, and obstructive shock can all present with hypotension and elevated lactate. But the therapy is very different. Invasive hemodynamics reduces diagnostic guessing and helps prevent reflex treatments that may actually worsen the patient. The macrohemodynamic divide. At the broadest level, cardiogenic shock usually shows low cardiac output, high filling pressures, high systemic vascular resistance, and low mixed venous saturation. Septic shock often starts with low resistance, preserved or high output, although late sepsis can become low output as well. The numbers tell you which side of the divide the patient is on. Shock is best understood as failure of oxygen delivery to meet tissue oxygen demand. Early in low output states, the body compensates by increasing oxygen extraction. So O2 rises and venous oxygen saturation falls. As perfusion worsens, veno-arterial carbon dioxide gap increases because blood flow is no longer adequate to wash out carbon dioxide, and lactate rises later once tissue hypoperfusion becomes more established. So the main point to remember is lactate should not be viewed in isolation. Real value comes from integrating O2 extraction ratio, central venous oxygen concentration, oxygen carbon dioxide gap. The hemodynamic context to recognize compensation is failing and shock is evolving. For O2 the practical bedside formula is O2 equals to SaO2 minus SvO2 divided by SaO2. Or if you're using central venous saturation as an estimate, then O2 equals to SaO2 minus S central venous oxygen divided by SaO2. Example, if arterial saturation is 98, venous is 68, oxygen extraction ratio 98 minus 68 by 98 or 0.31. The cascade of venous saturation and lactate complement each other. One tells you about balance between delivery and consumption, the other suggests anaerobic stress. Early on, when cardiac output begins to fall, the body compensates by extracting more oxygen, so the oxygen extraction ratio rises. As that happens, central venous oxygen saturation falls because less oxygen is returned into the venous circulation. If flow is inadequate, the venous to arterial carbon dioxide gap also widens, reflecting poor washout of carbon dioxide. Lactate is important, but is often later in the cascade. By the time lactate is clearly elevated, compensatory extraction is being exhausted, tissue hypoperfusion established. So the point is, do not look at lactate in isolation. Read oxygen extraction ratio, central venous oxygen concentration, and the carbon dioxide difference across the tissues. Normal tissues use only about 20 to 30% of the oxygen delivered to them. But as the flow falls, extraction rises. Once it gets above 60 to 80%, delivery is no longer meeting demand. A low SvCO2, high CO2 gap, and rising lactate provide a pointer towards evolving shock. Central venous signposts. Two useful signposts are venous oxygen saturation and veno-arterial carbon dioxide gap. A low venous saturation suggests inadequate delivery or excessive extraction. Increased carbon dioxide gap suggests low flow and poor washout. Neither metric should be used in isolation, but together they help identify whether circulation is meeting metabolic demand. Revisiting the sky stages. Returning to the sky stages. Remember the bedside logic. Stage A, at risk. Stage B, beginning hypotension or tachycardia without true hypoperfusion. Stage C, classic shock with clear hypoperfusion requiring active intervention. Stage D, deteriorating despite support. Stage E, extremis, where rescue options become limited and mortality is the highest. The right heart catheterization. The catheter is most valuable when the bedside picture is unclear, when therapies are failing, or when advanced support is being considered. It is especially useful in mixed shock, right ventricular failure, mechanical complications, and severe pulmonary hypertension. Used thoughtfully, it converts vague instability into measurable physiological problem. Cardiac output. A second look. This slide reinforces an important point: thermodilution and direct fig are not interchangeable in every patient. Severe tricuspid regurgitation shunts and low output states can distort measurements. So, when a number does not fit the clinical picture, do not anchor on it. Ask how was it obtained and whether the method itself may be misleading. If you assume oxygen consumption in shock, the assumed oxygen consumption can create a major error. The more unstable patient, the less likely a standard estimate reflects reality. That is why measured values, when available, are preferable. The big lesson is this: physiology becomes less forgiving as shock worsens, so shortcut assumptions become more dangerous. Assessing RV failure with PAPI. Right ventricular shock deserves special attention because it can be missed if we focus only on blood pressure. A low PAPI, high right atrial pressure, and systemic congestion should make you think about RV failure, whether from right ventricular infarction, pulmonary hypertension, or pulmonary embolic physiology. Right ventricle fails differently, and it should be treated differently. I'll pause here for a moment so you can look over the formula. Ventricular-atrial decoupling in sepsis. Septic shock is not only vasodilation. Many patients develop septic cardiomyopathy, so the ventricular and arterial system become uncoupled. Right heart catheterization quantifies ventricular-atrial decoupling by separating pump failure from vascular failure. It tells us how well the ventricle is generating forward flow with cardiac output and cardiac index, how vasodilated or vasoconstricted the arterial system is with the SVR, when the patient is underfilled or congested with PAWP and right atrial pressure, whether oxygen delivery is meeting demand with SVOT or SCVO2, It also gives a cardiac power output which combines pressure and flow into a single measure of how much hydraulic power the heart is delivering. That is why the swan is so useful therapeutically. If the mean arterial pressure is under 65, despite reasonable cardiac output, the main problem is vascular tone, so we titrate a vasopressor. If the cardiac index is below 2.2, despite adequate filling pressure, problem is contractility, so we add an inotrope. If both are abnormal, this is mixed shock, and the patient may need both strategies. If wedge pressure is low along with a low cardiac index, preload optimization may still help before escalating drugs. What is CPO? CPO stands for cardiac power output. It is a derived hemodynamic variable that integrates both flow and pressure, so it reflects the actual hydraulic power generated by the heart. It is calculated as CPO equals to MAP times cardiac output divided by 451. The mixed shock phenotype. Mixed shock is common in real life. A patient with myocardial dysfunction may also have sepsis, or a patient with advanced heart failure may become vasoplegic after surgery. These patients do not fit clean textbook boxes. Continuous invasive reassessment helps identify which component is dominant and how the balance is changing over time. Right heart catheter directed therapy, vasopressors, and inotropes. This is where numbers become treatment. If systemic vascular resistance is low, perfusion pressure is inadequate, vasopressors such as norepinephrine may be needed. If cardiac output is low, despite adequate pressure, an inotrope may be appropriate. The art is matching the drug to the hemodynamic problem rather than giving the same shock cocktail to everyone. Right heart catheter directed therapy. Fluid management. Fluid should be treated like a drug with an indication and an endpoint. Not every hypotensive patient needs more volume. Elevated filling pressures and pulmonary edema argue against further fluid and may point towards diuresis or mechanical support instead. Hemodynamics help us decide whether the patient is truly preload responsive or simply overloaded. When shock becomes progressive despite vasoactive therapy and hemodynamic optimization, it is time to think about mechanical circulatory support. The highest yield triggers are a patient in SCAI stages D or E with persistent hypoperfusion, cardiac index below 2.2, mean arterial pressure below 65 despite escalating support, or a severely depressed cardiac output, especially zero point 0.6 watts or less. In that setting, VA ECMO should be viewed as a bridge to recovery, bridge to decision, or a bridge to advanced therapy, not a destination. The VA ECMO works best when instituted before prolonged multi-organ injury becomes irreversible. So timing, patient selection, and shock center coordination are just as important as the device itself. Take-home points. Let me close with the practical take-home points. First, trust physiology over guesswork. Second, use right heart catheterization when the diagnosis or response to therapy is uncertain. Third, stage shock early and reassess often. Fourth, recognize mixed right-sided phenotypes. And finally, remember the goal is not more data, it is better and earlier decisions. Thank you for watching. More to follow.